Good morning, everyone, and thank you for coming for this session of Meet the Expert. You know what is strange? When we become surgeons, when we become doctors, we study very hard to get our MBBS and to have a doctor before our name. But when we become surgeons, we study very harder to lose the doctor and just become Mr. or Miss. So similarly, when we train as a surgeon, we start off learning when to operate. But when we become master, we learn when not to operate. So today we are very fortunate that we have got three experts who are masters in their art of trauma and who are going to teach us when not to operate. So the three of them, we have Mr. Yuzaidi, who is currently in Hospital Sultan Amina. He's a trauma fellow. And with him, we have Miss Tiong. She is just back from her training, and so she has a lot of new knowledge to share with us. And lastly, we have Mr. Azuddin. He is the head of Department of Surgery in one of the busiest hospitals in Malaysia, which is Hospital Tunku Ampuan Rahimah. So we are very fortunate that we have three experts to share with us whatever we can learn about when not to operate. So can I pass it over to our moderator, Dr. Izwan?
Yeah, thank you. Thank you, Mr. Andreas. All right. Okay, Assalamualaikum and a very good morning to everyone. So welcome to our Meet the Expert session for trauma surgery today. So I am Mr. Izwan Ismail, your moderator for today. All right, so our topic of discussion today will be non-operative management of injured patients. Is it the bane of trauma surgeons? Mr. Andreas have give a kind introduction for our speakers, our panelists today. Mr. Yuzaidi Mohamad, consultant trauma and general surgeon from Hospital Sultan Amina, Johor Bahru. He did his fellowship in trauma and acute care surgery in Singapore. Our second panelist speaker, Mr. Azuddin Khairy, consultant trauma surgeon and head of the general surgery department, Hospital Tunku Ampuan Rahimah, Klang. He did his fellowship in trauma and acute care surgery in United Kingdom. And our last speaker, our last panelist is Miss Tiong, Vun-E, general and trauma surgeon in Hospital Tunku Ampuan Rahimah, Klang. She did her fellowship in trauma and acute care surgery in New Zealand recently. Okay. All right. So the format of our today will be a forum-like. So I will ask a couple of series of questions to our panelists, our speakers, and they will take turns answering them. Okay. So to start with, our first question today, I would like to ask Mr. Yuzaidi. Okay, Mr. Yuzaidi. Non-operative management of injured patient, or in short form, we call it NOM, has its humbling beginnings in the realm of adult trauma surgery practice. So can you tell us a bit more how NOM starts, what are its objectives, and what are the principles of NOM? Mr. Yuzaidi.
Okay, Assalamualaikum and very good morning. It is a great honor to be here today, joining everyone in the webinar, even though we cannot see everyone face to face, but at least we can see your face on the website. I would like to share my slide so that you can have an overview what is NOM is all about. Okay, non-operative management of injured patient, is it the bane of trauma surgeon? As like what Mr. Das said, when you become senior and senior, you will be given the task of making a decision not to operate on someone. You know, like my previous prof has said, it takes you 5 years to learn how to do surgery, another 5 years to learn how to do the surgery. First 5 years how to do surgery. Next 5 years learning how to make a decision how to do the surgery, and the last one learn how to make a decision not to do a surgery. So it is quite difficult task actually to make a decision not to do a surgery. on a patient. Okay, as an overview, non-operative management is surgical perspective of blunt and penetrating can be very challenging. For the past 3 to 5 decades, there was a major shift on management from operative intervention or non-operative intervention because of better imaging modalities like a CT scan, which is available in almost major hospitals in our country and overseas. Nowadays, we have more than 50 plus hospitals in our country under KKM, which has a CT scan. The trend of managing non-operatively started off by the pediatric team, in which they have successfully managed spinning and hepatic injury in pediatric age group, and they have a very good success rate. Okay, how about penetrating injury? It's divided into few periods. I mean, non-operative management was standard care through most of the 19th century. I think possibly due to lack of facilities, and expertise. Very high mortality back then. So after towards the end of 19th century, the American Surgical Association recommended operative management or surgical approaches for civilian penetrating abdominal wound. And then it became standard procedure during the World War I and all the way to late 1900 or early 1900. So after World War II, it was mandatory surgical exploration for all civilians with a gunshot wound. So we learned a lot from war, the injury and the management. So we learned a lot from war. War is making money basically. After 1970s, they introduced selective non-operative management, and it became a trend in managing abdominal trauma wound or stab wound. After 1990s, in selective non-operative management being practiced in many major trauma centers, like in South Africa, major trauma centers, they selectively manage penetrating or gunshot wound non-operatively. That's the only center that I know of currently, which has about 100 plus trauma beds in their ward and ICUs. So they manage like thousands of gunshot wounds every year. Right. What are the objectives of non-operative management? Basically, you want to prevent unnecessary surgery, which is divided into non-therapeutic or negative surgery. I'll talk about this later. And it will prevent complications associated with surgical management. One is GA risk. Some patients have a lot of complications after the GA. Post-op complication like OPSI, SSI, OPSI, post-perenectomy syndrome, infection, which carries very high mortality. Heterogeneous injury, post-perenectomy, patient develop pancreatic fistula, for example. You accidentally cut the pancreatic duct during the perenectomy process. It has happened before, I'm seen it. Non-operative management also known to reduce cost of treatment, especially in advanced country in which the cost of doing a laparotomy itself will be in thousands of dollars. In Malaysia, you don't see it because majority of these patients will end up in government hospital or public hospital, but the actual cost is actually very, very high. Okay, surgical management can be divided into 4 categories. Therapeutic, if the surgery requires repair were found. That means you open up, there's a bowel injury, then you have to repair, that's considered therapeutic. Non-therapeutic, if injuries do not require intervention, when you open up, it's just cerebral bowel injury, nothing that you can do or nothing much that you should do. Can be as the non-therapeutic laparotomy incident can be as high as 40%, and the complication can be as high as 26%. How about negative laparotomy? When no intra-abdominal injury were found, you open up for example, for peritonitis on the suggestive of peritonitis, we open nothing, clean abdomen. So the patient will end up with maybe can end up with SSI, can end up with additions. The most common indication for laparotomy, for negative laparotomy, is one is peritonitis, followed by hypotension. The patient hypotensive, you don't know what's the cause, you have to open up sometimes, but not always. That's why clinical examination is very, very prudent. And a suspicious image on CT scan also is another indication why we end up in negative laparotomy. So all this we consider as unnecessary laparotomies or non-therapeutic and negative laparotomy. So what are the complications associated with non-operative management? One is missed injury. Remember, 1/3 of the patient, and when you do non-operative laparotomy, you can miss injuries, which can be fatal and can be medico-legal. 2, delay in diagnosis and treatment. Educate your delay resuscitation, detained hematoma, and so on. Oh, how to practice do non-operative management in your center? 1, patient selection. You must have a good clinical evaluation and accurate diagnosis before you subject the patient for non-operative management for a patient. For example, the patient comes to you with blunt abdominal trauma. We cannot just do clinical examination. Simple ultrasound alone won't be enough. So most of the time when patients come to you suspected intra-abdominal injury, query spleen injury, a bit of fluid, hemodynamic stable, we will subject the patient for better imaging modalities such as a CT scan and so on. That means all these patients cannot be managed in a district hospital without any specialist. No? Second strategy, you need to have a very good radiological modalities, a CT scan, MRI, ERCP, and so on and so forth. How about facilities? You need a proper monitoring in your ward. You must have a good maintenance system. Your staff, HDU, must have a good HDU, ICU, OT, which should be all readily available 24/7. Your staff must be trained, the surgeons, 24/7 in the hospital, for example. The anesthetic colleague know what you are doing, so they can open up OT anytime. And you should also have a guideline and protocol in your hospital. Must have a leadership who can decide what to do and know what not to be done. Okay. Last but not least, operating management should be available and executed properly if indicated. Any time of the day, even at 2 a.m., 4 a.m. Okay, basically, most of solid organ injury can be managed non-operatively, like liver, spleen, pancreas, and kidney, provided you have a good imaging modalities, CT, you have continuous monitoring, even grade 3 to 5 kidney injury can be non-operative, which is commonly done in our center. Liver injury, which is also commonly managed non-operatively. All right, I would like to share one simple case to start off with. Okay, we have a 22 years old guy, MVA motorbike versus car, around 60 to 70 km per hour. Quite recently, even though now is a MCO, but people still traveling. You have to go to work. So MVA or road traffic accident occur yesterday, occur today, and will be occurring tomorrow and day after that. It will be non-stop. So this guy presented to us with multiple abrasion wound, extremity, intra-abdominal, and suspected chest injuries. Okay, GCS 13/15, blood pressure 90 to 100, systolic pulse rate of 110 to 120, SpO2 95%, pulse positive, standard left hypochondrium, no generalized peritonitis. Given 1 liter saline, 1 unit PEC cell given. In our center, usually if the patient come with borderline BP 90 to 100 with history of mechanism of injury quite severe, they will give blood quite early. So HB was 10, ABG not acidotic. Radiologically, he has multiple left rib fracture with minimal hemothorax, pelvic assay was normal, extremities right, commited tibia fibula fracture. So in this type of patient, since the vital signs is quite stable, the systolic BP more than 90 and AP more than 60, we will subject this patient for non-operative management most of the time. So what we do, usually we get a proper imaging, we do a CT scan. You can see here, there is a moderate free fluid. This is moderate free fluid, 1 quadrant, 3 quadrant. 1 around the splenic area, 2 liver, and also pelvic. It's a moderate free fluid. When you have a moderate fit, means that here 20%, 20%, 20% chances of the patient to, that means 60% chances of the patient to fail in the non-operative management. Every quadrant roughly about 20% chances of failure of non-operative management. However, in this patient, even though he has grade 4 regional spinning injury with moderate fit, but on the CT scan of the skin, we don't see any arterial blush. So in this type of patient, we will usually manage non-operatively by close observation 24/7. So in summary, this patient has spinning injury grade 4, inner injury grade 3, left 4 to 9 rib fracture, bilateral lung contusion, left pneumothorax, right tibial fibula fracture with NISS score. Means this NISS means new injury severity score is 34, or ISS category of 29 is considered as major trauma. Major trauma means if your ISS more than 16. So so the patient was closely monitored in surgical ward, acute cubicle, followed by fixation of fracture on day 3, and after that patient discharged home on day 7. So this is another example of patient who came to us 35 years old with severe liver injury grade 4, liver injury with quite significant free fluid in the pelvic cavity. That means roughly about 1 liter of free fluid in the abdominal cavity. But we managed this patient non-operatively. After 1 week or so, we did a repeat CT. The free fluid is no more there. Okay. So back to the question, non-operative management of injured patient, is it the bane of trauma surgeon? Well, managing severely injured patient non-operatively can be very difficult to make a decision, and you need a senior staff or those who are very experienced to make that decision. And you need to press the correct button to manage this type of patient. Okay, with that, thank you.
Okay, thank you, Mr. Yuzaidi. So it's quite interesting to know the history of NOM. I think the correct term nowadays that we should use is a selective NOM for patient that requires NOM. Okay, all right. So the idea of treating injuries NOM does not mean that we are not doing anything. So and it entails a lot of ancillary steps and procedures. So can I get Mr. Azuddin's view on the requirement of performing NOM in hospital like in Klang that has a trauma system in place? Yes, I'm sure that the safety of patient is of paramount importance. Mr. Azuddin?
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you very much, Mr. Izwan, for the kind introduction. And thank you to College of Surgeons for inviting me again to this prestigious conference. I'm sorry, there's some technical problem. Let me share my slide again. Okay, I will start my, first and foremost, I have to declare that I have no conflict of interest. I will start my presentation by giving a case scenario on how non-operative management can be applied not only to the blunt trauma, like what Mr. Yuzaidi presented just now, but it also can apply to the penetrating trauma patient. Okay, this is a young guy who sustained a close-range gunshot injury to the chest wall. He was driving a car and stopped at the traffic light, and suddenly 2 unknown persons riding on the same motorbike stopped near his car window and shot him multiple times using a handgun. He was then brought to the nearby hospital by the ambulance. When he arrived, he was tachypneic and he also have an episode of hypotension. Primary survey done revealed that there was a decreased air entry bilaterally over his lung, hence bilateral chest tube was inserted. However, his GCS still full. On clinical examination, there is a 9 gunshot wound over his chest wall, chest area, and some of the wound is near the cardiac box. On further examination, patient noted he was unable to move both his lower limb. In principle of managing gunshot injury, the importance of counting and identify the wound is very crucial, as we have to see where is the entry of the penetrating wound and where the exit wound. So then we can decide the trajectory of the bullet and possible organ injured. In this patient, there is an odd number of wounds, means that probably another bullet still lodged inside the patient body. This is a check X-ray done in the district hospital. As you can see, it's not a very good X-ray because it was a portable X-ray. And the chest X-ray showed that the bullet is somewhere in the midline, where all the vital organ was there, like your heart, esophagus, trachea, probably it's an aorta, or probably it's in the spine area. So then patient was then prepared to send to hospital Tunggal Paramah Klang. In Klang, we have a pre-hospital trauma activation protocol when there's a very ill case is coming, or whether there's a massive casualty is coming. The ED is prepared, the beds, the CT scan was put in alert and was stopped doing for elective or any other emergency cases. The HOT is on hold and prepared for this patient to be pushed to OT if needed. Once the patient arrived to our hospital, when we examined the patient, he was fairly hemodynamically stable. And we noted that both the chest drain only have about 300 ml to 400 ml of blood. So with the multiple gunshot injury at this point of time, what do you think what is your next step? Whether you want to bring the patient straight away to OT or for thoracotomy and exploration, as what the guideline last time, the old guideline said that all the penetrating wound have to be explored, or do you want to proceed with imaging modalities? So for this patient, we did a CT scan of the chest, abdomen, and pelvis, which show that the bullet trajectory passed through the right lung and also passed across the vertebral body of the T5 and T6, causing a spinal injury. The other bullet trajectory just passed through both lungs without injuring any other vital organ nearby. So for this patient, we treat non-operatively in HDW with close monitoring. The patient also is not intubated for airway protection because this was successfully managed. And then we know that the hypotension is not because of the bleeding, because of this spinal shock. And he recovered well without needing any further surgical intervention and discharged well on post-op day 12. However, unfortunately, the paraplegia that patient have is permanent. So we come back to Mr. Izwan's question regarding requirement to treat non-operative management in trauma patient. The non-operative management relies heavily on the availability of trauma-trained surgeons who have a vast experience in managing operative management in trauma and know when to decide to operate and not to operate. We also need advanced radiographic imaging CT scan, probably 64 slides or above. 128 is the best, with accurate interpretation of such quality image. Especially when we are in doubt, we can do a 3D reconstruction to identify and confirm the diagnosis. We also need a specialized institutional support and infrastructure, such like what Mr. Yuzaidi said just now, such as an angio suite and very intensive care service, transfusion medicine to support us for to manage the severely injured patient non-operatively. The NOM ideally can only be done in the hospital that is able to provide a definitive care of the injury sustained. Please be aware that the non-operative management is an active management. It's not a wait and see approach. It requires a vast knowledge and accurate clinical judgment when come into a decision making. And it is a continuous assessment process that needs a dedicated team management and multidisciplinary discussion in between departments headed by trauma surgeons. The non-operative management also requires a specific clinical pathway and protocol. For example, when you monitoring the patient, how much blood and maintenance fluid to give, and when to repeat the imaging for the non-operative management of the liver and renal injury and others. It also needs a standard operating procedure to be put in place and understood by all members of the managing team as to avoid miscommunication and mismanagement of care plan. We also need resource in the sense of facilities, hardware, manpower, and expertise, as I mentioned before. And the most important thing, at all times, this resource should be made available in case there is fail of non-operative management, and any delay in operation treatment will only harm the patient. I would like to share a few principles of non-operative management. In managing non-operative management, mechanism of injury is important so that we can anticipate what kind of injury we are facing with, whether it's a blunt or penetrating, whether it's a low or high velocity injury, and others. You must get info exactly from the patient or from the pre-hospital care person regarding the severity of the mechanism. Physical examination also is the key to the non-operative management. When you examine the patient, when there is a peritonitis, of course, it's not a candidate for non-operative management. The patient should have a very clear mental status so that you can identify and correlate the sign with the imaging studies. Hemodynamic stability is a must in non-operative management, and we have to be cautious in patients who came with polytrauma, because when there is multiple organ injury, we should have to decide and to give a priority to protect first the central nervous system and also the cardiovascular system. We also need a reliable healthcare personnel which can perform frequent physical examination so any deterioration of the patient can be detected early. They should be able to arrange planned re-imaging and repeat necessary blood investigation as per protocol. Of course, we need ward or HDW or even ICU for close monitoring of our non-operative management patient, and we need OT availability by all the time. Besides the general principle of non-operative management we have discussed just now, there is extra rule specifically applied to the penetrating injury patient. We have to establish adequate trajectory of penetrating injury when it is, because it results on injury identification. Managing an operative management for penetrating injury is more complex, and it depends on either it's a mechanism-based consideration, for example, the severity of injury performed by the penetrating military compared to the civilian penetrating wound. But most of the time, it depends on regional anatomy base. For example, the location of the stab wound in the anterior part of the abdominal wall is managed differently when it occurs at the loin. Non-operative management treatment in trauma should not be labeled as easy or a non-expert management. We have to maintain high index of suspicion all the time when come into especially polytrauma patients who need a non-operative management. Thank you very much.
Okay, thank you, Mr. Azuddin. So I like your quote that everyone should understand that NOM is an active management. It's not a wait and see approach. So there are principles and principle that we need to stick if we want to choose for NOM. Okay, all right. So for participants, if you have questions, you can write in the chat box. So maybe at the end of the session, if we have time, I will choose 1 or 2 questions to be answered live. But other question will be answered by our panelists, our speakers in the chat box. Okay. So next, Ms. Tiong. Mr. Yuzaidi and Mr. Azuddin have mentioned that one of the strategies involved in NOM is the use of interventional radiology services, endovascular interventions. So what is your take on the use of interventional radiology and endovascular procedure in trauma? Ms. Tiong.
Good morning, everyone. Thank you for the opportunity to talk in this session. I have been tasked to answer the question of what is the role of the interventional radiologist in trauma care. Hold on, just let me find and share my slides. Okay, so as mentioned before, the possibility of managing a patient non-operatively, this is brought about because we have so many people that can actually, that's the only options. IR and stenting and embolization is also one of the very important pillars of managing a patient non-operatively. I will just concentrate mainly on endovascular injuries, vascular injuries per se. So an IR is a very good friend to any trauma surgeons. They can do a lot of things. Traditionally, radiologists were just diagnostics. So they run images and tell you what the injuries are, but now they can actually do something to help you. They are capable of embolizing blood vessels, of stopping bleeding. If you have a thrombosed vessel, they can actually recannulate it with endovascular stents. So they are things that they can help. As the primary surgeon, I think that there are decisions that have to be made by the surgeon in a sense that who are suitable for intervention and who are not. So who are the ones that we are that we should think of calling the IR? So I think the overriding principle is that for non-operative or minimal invasive interventions, the patient has to be stable. He has to be able to maintain his status until the end of the procedure. And sometimes they may start off stable, but during pre-transfer or during the intervention, they may deteriorate. So it's something that's quite dynamic, and it's not something that we should just pass over to the IR and let them do their thing. So in a lot of instances, the surgeon would actually accompany the patient to the IR suite, and if needed, to the OT from there if it fails. In terms of anatomy, which are the vessels which are suitable for intervention? Grossly overall, these are the ones that are in the trunk itself, the deep vessels. So the aortas, now by far, endovascular stenting has kind of overtaken open repair, and it's been shown to be as good as, or sometimes even better for the patient. So aortic injuries are a good option. Vessels that are junctional, so at the subclavian areas, at the zone 1 of your neck vessels, at junctional vessels like in your inguinal groin area, iliac vessels. So those are difficult vessels to get to surgically. For a surgeon to get access to it, you actually have to cut open and make a big wound. So that is something that's potentially avoidable if you have an IR friend with you. Regarding the grade of injury itself, so sometimes when you have stable patients who end up going to the CT suite, you pick up things like a blush, or there's a pseudoaneurysm that you find. So what do you do with these patients? I have two very quick slides to show. This is actually one shared by Mr. Yus, which they had recently. This is a Chinese uncle who was on his motorbike and was hit by a car, and essentially had an impact on his left side. Clinically, there was nothing too apparent other than a bit of a bruise over his left groin area. So he had a CT scan done because the index of suspicion was high. So if this is a 3D recon of the soft tissue vascular reconstruction, so if you can see that there's actually a filling defect here at his left external iliac vessel. So he had his pulses. There was no active bleeding from that area. So what do you do next? So in this case, we will need to think of, yes, there's no problems right now, but do you need to consider a risk of him developing chronic ischemia later? Will he develop coagulation? Will he develop tissue loss later down the line? So there was a discussion between different disciplines, and they do have IR services there, which is a good thing for patient, because what happened to him is essentially the IR helped in putting in an endovascular stent there. So that's the stent that was placed, and this is the completion angiogram. So you see that the vessel has actually been opened up by the stent, and there is complete flow with no extravasation of contrast. So this is something that is good for the patient. Talking about grades of injury. So this is a patient that I had last month who came in. He was a motorcyclist as well, who fell on his left side of his body. So when he came in, his hemodynamic status was actually pretty okay. He had very good hemodynamic stable signs. His BP was all the while okay. His heart rate was just in the 60s. Full GCS, no respiratory problems, but he had a positive fast scan. So we had a CT scan done for this patient. And let me just play that. Oh dear. So that's free fluid that you can see there. And then if I can direct you to the spleen area, so you have multiple left-sided rib fractures there. This is a large perinephric, perisplenic hematoma, and that's actually extravasation of contrast. And then just going down a little bit further, there was a little bit of a streakiness around the renal area. So that's just a very minor grade 1 renal injury. So if you have patients like this who are very, very stable clinically, his GCS was full, his HB was 15, his hemodynamic status maintained over the while. So what's next step for him in view of his being hemodynamically stable? Do you want to watch him? And if you want to watch him, how long do you want to wait? Do you want to repeat a CT scan? So these are the questions that we will need to decide once you have all this pertinent information. So for this patient, ideally, because he's so very stable and he would have extra comorbid risk factors if you bring him to theatre, ideally, IR services would be good for him in the sense that you can have a minimally invasive procedure that can essentially embolize the splenic vessels. So for this patient, he actually came in at 1 a.m. in the morning, and it's at the time where COVID is all the rage in the Klang Valley. We don't have an in-house hospital IR personnel, so our likelihood will need to refer him out. So because of the circumstances, we are not able to offer him any IR services. So this patient had his spleen taken out on the same night. So I think the big question in Malaysia in our current setting is essentially how available and how accessible are IR services available. In Klang Valley, they are IR. They are now in Sungai Buloh, in Selayang, and in university hospitals. So it's something that is available, but because of the context, you've got to take into account factors. So transferring patients itself is not easy. You cannot just refer off of a patient and not do anything. While waiting for transport, the patient may deteriorate, or during the intervention itself, the patient can deteriorate. So you will have to let the surgeon in the receiving hospital know. So logistics and communication is very, very important. And timing also, let's say if you have a patient who comes in at 2 a.m. in the morning, how visible and how different will it be if he comes in as opposed to office hours? And it's not just regarding just the logistics of it, there will be technicalities of it. So the IR will have to see anatomy-wise, is it feasible and amenable technically? So does he have an access port? Does he have the correct size of his guide wires or sheaths? And does he have the required coils? So there's a lot of technicalities which are also involved. The other thing is timing. So arranging for a an intervention like this with a patient who can potentially deteriorate at any time, how smooth and how well it's organized, it's very important. So established centers like the one that I worked in New Zealand, they had code activation. So they have something what is known as code crimson. So this is actually for patients who are hemodynamically unstable at the scene. So it's activated by paramedics before they actually reach hospital. So once this code crimson goes out, a lot of people in different disciplines get informed and they go in a standby mode. So the blood bank gets to know of that this patient is coming in, the trauma surgeons, the head of the surgical department, ICU, there's a CT suite which is cleared off on standby for this patient, the IR comes in. So if you have protocols like this, it tends to help with timing and logistics and smoothen out the flow. But at the end of the day, as mentioned, the one who is primarily responsible for the patient is the primary surgeon, who is trauma trained, because having said a lot of things that can be done for a patient to manage him outside of the OT, but there's always a possibility of things failing and not going according to plan, and complications can also arise. So at the end of the day, it's the call of the surgeon. So in a nutshell, to answer the question, does the IR have a role in trauma? Yes, they do. It's a very good option, a very feasible option in the things that you can do for patients. However, there are a lot of factors that you need to be aware of. And at the end of the day, the primary person who makes decisions, hopefully appropriately, would be the primary surgeon.
Okay, so I do agree with you, Ms. Tiong, that IR services is very helpful in us managing traumatic injured patient. Okay, all right. So now, Mr. Yuzaidi, for the next question. So let's say if NOM can be so successful undertaken for injured patient, so is it possible for patients to be treated without admission under the surgical team? For instance, we put the patient in the observation ward in ED, where the patient are managed by the physicians, and intervention are decided, and patient are then monitored there, never to be in contact with a surgical team. So can we do that, Mr. Yuzaidi?
Managing simple case, yes. Small wound, small little fracture, finger fracture, but for severely injured patient to be managed non-operatively in emergency department, for example, I have never heard of any patient that is able to be managed non-operatively to be stationed in ED for more than few hours. They will usually be managed in the ward, and the management of the patient must be entrusted to those who can manage patient non-operatively, operatively and definitely, and the patient must be managed by the primary team, be it surgery, ortho, neurosurgery, and so on and so forth in their respective unit. Why this is so? Because we have easy access for the surgeon, for the orthopedic surgeon, for the neurosurgeon. They have easy access to early intervention. They can call their colleagues, notice, anesthetists, ICU, because the patient is in front of their eyes. The question is, what if non-operative management fails? If it's successful, yes, but what if NOM fails? So not the other way around. That's why we need to have easy access, and patients should be in front of our eyes. Maybe in some centers, in advanced centers, I don't know, but maybe they practice this and because they can ensure easy access to early intervention. But in all places where I practiced before, we don't lodge patient, severely injured patient in ED, if it's for non-operative management.
All right. So I do agree with you, Mr. Yuzaidi. So for severely injured patient, polytrauma patient should be referred or seen by the primary team, especially the ones that we can do a definitive management for the patient. Okay.
Yes, usually because like some of the center, like my center, we have in-house general surgeon on call 24/7. So the patient can be seen within minutes by the on-call team, by the general surgeon, and we have also 2 trauma surgeons around to help imaging such a severely injured patient.
Okay, all right. Okay, so let's go to Mr. Azuddin. So it seems apparent that NOM requires a lot of transboundary cooperation of different disciplines. So all this comes with a cost. So Mr. Azuddin, can you share with us your experience in HTA Klang in facing this problem? Your speaker, your mic, Mr. Azuddin.
Okay, sorry. Thank you for that question. I've been in Klang since 2015, 2016 officially after I have my fellowship in trauma. So for me to achieve a trauma center of excellence for trauma that can be successfully manage trauma patient non-operatively, what we need is to get all the department involved together into a same page. First, we have to form a trauma committee at hospital level, and this trauma committee should be endorsed probably up to the, not only at the level, probably to the state or to the national level. After we develop a trauma committee, then you have to develop a trauma team. When the trauma team should work into a trauma system at your hospital level, and you should provide a guideline according to your needs and facilities availability in your hospital. The essential department that should contribute to cater or to treat the trauma patient, especially for the non-operative management, is the surgical department itself, the ED, the radiology department, NS, transfusion medicine, ortho, and even a physio and rehabilitation unit. The patient who is candidate for non-operative management also need a very dedicated bed in ED for continuous monitoring, need a high resolution CT scan machine to identify and accurately diagnose all the injury. And once patient already confirmed to be managed non-operatively, patient need a dedicated ward, HDU, ICU for a continuous monitoring. So what have happened in HTA or Tunku Ampel Rahimah Hospital, we have actually made one ward into a trauma bed ward, like what Mr. Yuzaidi said just now in South Africa. We are the only hospital in Malaysia who have a dedicated trauma ward, bedded about 40 beds, and we totally manage the trauma patient there. Through the trauma committee, we can conduct a platform for discussion for improvement of trauma service. We also need to explain to them the needful and the benefit of non-operative management to show all the department will work together. So just now when there's a lot of department involved in managing trauma patient, we need to coordinate incorporation of trauma care into a budgeting process. We need to upgrade our infrastructure and medical device and equipment. For example, we should have our own angio suite with high-end fluoroscopy machine for radiological interventional service in NOM, and also the ERCP machine, ERCP scope, and also the fluoroscopy. This resource will, of course, need a lot of money coming from the ministry, and this resource should be shared by many disciplines for a common pathology, which is our trauma patient.
Okay, Mr. Azuddin. So we can say that for us to manage coding NOM, so we need a very good trauma team, a good multidisciplinary cooperation, and also, last but not least, we need a budget for trauma, right?
Yeah, exactly.
Yes. Okay. All right. So, Ms. Tiong, just a quick view of your view about liberal use of CT scans. So, what are the role of pen scan? So, should all trauma patients in ED who came to ED receive a pen scan? What's your view?
That's actually a very difficult question to answer. Okay, I do agree that you do need very detailed imaging for you to decide to manage this patient non-operatively. So the ones that come in at either end of the spectrum, so very minor, simple, isolated injuries, and the ones at the other extreme, the ones who come in polytrauma, unstable, those ones are no issue because you already know what to do with them. But the vast majority of the patients actually come in the between, so they are stable, but you still need a very organized and fast way to actually pick up injuries. So how do you decide how much to scan? I don't think there's any correct answer in the sense, but essentially what are the things that should go through your mind is what do you anticipate the injuries are in this patient? And then there are a couple of practical things that I would think of. So three categories to look into. So one is the mechanism. How did the patient get this injury? So if you have a patient who comes in with high impact, the higher your risk of getting injuries and the lower your threshold of scanning. So patients who have had a death on site or were ejected from a vehicle or who had a significant fall from height, for these patients, my threshold would be lower. Number two is how's their physiology. If they come in with a BP that was initially low, or they had a low GCS and you can't really access them properly, my threshold would be lower. In terms of anatomy of injury, so if they have multi-regional injuries, head injury and a pelvic injury, anything in between them is actually fair game for impact to get injuries. So patients like this, I will lower my threshold. So it depends on what your clinical judgment and clinical assessment is, and according to that, your threshold moves up or moves down. Traditionally, we have always gone on a step-to-step kind of as an ATLS teaching, as you do your x-rays first and then your fast scan, and then from that, you target the systems that you are afraid of. But recently, yes, there has been an entity pan scan or whole body scan, where essentially they just scan you from head to your pelvic area. Pros and cons. So pros for fast scans, for pan scans, is you get a lot of information in a very short period of time. But of course, they have to be stable and the usual things that we talked about earlier to go. The cons of it is that you do get radiation exposure. So the majority of patients in trauma are young. So the younger you are and the more radiation you're exposed to them, there's always a possibility of occult or delayed malignancy going on. So that's something that you have to keep in mind. There are no major studies that I can think of broadly. There was an RCT done comparing traditional pen and what are the mortality rates, and it's found to be there's no difference in in-house mortality. There's no clinical difference in the time that you get to diagnosis. So at the end of the day, I think we should still rely on our clinical judgment. You don't use a pan CT and indiscriminately scan everybody. It also depends on your resources. Not every radiologist will be as enthusiastic to scan as you want. So depends on your local context, I guess, at the end of the day, what you feel, and are you able to get your radiologist to get on board, same page as you are.
Okay, I do agree. So, but then who should, for PAN CT, so who should request for it? Is it the primary team or the referring team? Who should decide on PAN scan?
I think it should be the primary team, because they will be the ones who's actually going to manage the patient. So I think it's only fair and appropriate that they know what they're getting into.
Okay, all right. Okay, I think we have another 7 minutes for this session. Maybe the last question I will give to Mr. Yuzaidi, and then I'll choose 1 or 2 questions from the audience. But then some of the questions have been answered by our panelists in the chat box. So Mr. Yuzaidi, just for the last question, so can you share your experience with the use of transfusion medicine in NOM of injuries?
Okay, in general, managing injured patient is a team sport, and transfusion medicine is one of our teammates. You need to have a very good support by the transfusion medicine specialist. There's a limited role of a lot of blood transfusion for NOM patients, as any patient that require more than 2 units of PEG cell plus other products to maintain his hemodynamics. 1, to maintain patient hemodynamic by using inotropic support. Also, upon admission is considered not for non-operative management. Example, if you have a liver or spinning injury and he requires more than 2 units of XL upon admission, then he needs an urgent intervention, be it interventional radiology equipment or surgical intervention. Having said that, in the event of sulfate failure and patient require massive transfusion, we have a MTP in our center, massive transfusion protocol. We started in 2015. The committee consists of trauma surgeon, transfusion specialist, EP, anesthesiologist, and higher level management team, hospital director, and so on. So we prepare a protocol, proper protocol, and how to activate MTP, delivery of blood and products, And towards the end, how to terminate it, because even though you have a proper protocol, you have to know how to terminate the protocol, because the blood will keep coming in until you ask them to stop. So we also conducted drills among all the team members, and to make sure everyone knows. That means your surgical team, your anesthetist team, EP know how to activate, how to use this protocol. Otherwise, there will be a lot of wastage of blood and product, and it's quite expensive. So we did a review on this, and we review our data yearly. So we did a meeting, and based on the review and audit, our latest guideline has been revised to the latest one, 2020. If everyone want to know our MTP, you can always we can always share with you how we do it.
Okay, thank you, Mr. Zadi. I think in trauma centers like in Sultanate Aminah Johor Bahru and also Klang, Klang, so we have our own protocol of MTP. So we can get easily available the blood without any wastage. Okay, I think
not only MTP protocol. In our center, we also have a protocol for all injuries that we have to manage.
Okay.
Not all, almost all.
That's true. Okay. Okay, all right. So I think we are entering the last 4 minutes of our session. So I'll choose 1 or 2 questions from our chat box that is quite interesting. I think some of it have been answered by our panelists. Okay, all right. So this question here, I think any panelist can answer. So in centers with on-site subspecialty surgeons like HPB, urology, so where do you see their roles in management of trauma patient, especially in relation to NOM? So any of our panelists would like to answer the question?
Azuddin?
Come back the question. I just actually missed the question.
So I mean centers like centers with subspecialty surgeons like in HPB, urology. So what are their where do you see their roles in management of trauma patient, especially in NOM?
Okay. I'm working in Hospital Tunku Ampan Rahimah Hospital, which don't have any other subspecialty other than trauma, and it's common for the trauma surgeon to become the head of the trauma team and get all the people together to manage the trauma. In a center which that's like HPB, neurosurgery, urology, that is the very important component in managing a trauma patient, but there must be someone who actually just look into a trauma, organize everything, make sure the things been done. So what we call as what in the UK they call is like a umbrella approach or umbrella system, where there's somebody above that of course cannot do all the management that what the subspecialty manage, but they can actually become a person or licensed person to discuss to them for the care of the trauma patient. So not any other component that can be neglected through the journey of the trauma patient in the ward.
Okay, all right. Thank you, Mr. Azuddin.
I'd like to respond to that. I'm working in a hospital in which we have HPV surgeon and urologist. So where do you see their role? Their role is mainly if the patient develops a lot of complications, for example, in which towards the end or after many days in ward, patient require their intervention. So only then we refer to them, especially for high-grade renal injury, for example. No? Otherwise, most of the time in our center, HPB will mainly manage elective cases and all CA cases. They concentrate on doing that. We concentrate on doing all the trauma patient liver injury. Even if there's a significant liver injury require intervention in our center, we do on our own. For example, liver resection, what they call resection of debridement, ERCP. So all this will be done by most of the time by us. No, urology also the same. If patient is unstable, we do bladder repair, we do nephrectomy on our own for unstable patient. But if the patient requires stenting, for example, special procedure, then we will refer to urology. Urethral injury, for example, then urology will come in.
All right. Okay. So thank you both, Mr. Azuddin, Mr. Yuzaidi. I think I just take the last one question. This is for Ms. Tiong. So do you think the role of trauma surgeon will diminish as a result of the trend of increasingly treating injured patient non-operatively?
I'm going to say no, and I'm going to frame it in the sense that because patients are managed more and more non-operatively, I think the role of the surgeon actually is all the more important, because now there's a lot of people, a lot of disciplines who are actually getting involved in trauma care. So you have the EP, you have the ICU, the intensivist, the IR. So modern trauma care is actually more of a team sport rather than a single player game kind of scenario. So as any team, I think there should be a captain, because at the end of the day, he is the one who will be responsible for the overall care from acute all the way to discharge and rehab. When you put the patient for non-operative management, you are essentially accepting a risk that there is a possibility of failure for non-operative management. So you have to be aware and be able to pick up subtle signs of that, yes, this patient is not going very well, and I should therefore consider bringing this patient to OT. In a nutshell, no, I think there is always a role for a primary surgeon who is trained in trauma.
Okay, all right. Thank you, Mr. Tiong. I think okay, that wraps up our session today. So in summary, I would like to summarize that NOM can be challenging. So it relies heavily on the availability of trauma-trained surgeons, advanced neurological imaging, accurate interpretation of high-quality radiographic images, and specialized institutional support and infrastructure. So again, thank you very much to all the panelists, to all the speakers. Thank you for to the audience for the questions. So if you're interested more to know about trauma surgery, our protocols, you can ask any one of us. Okay, either in JB or in Klang or in Sungai Buloh. We also have our trauma surgeon in Sungai Buloh, Mr. Ashok. Okay, mainly we have protocols for every injured patient. We have our own guidelines, and we are coming up. We have our first edition, so we're coming up with a newly updated second edition soon. Okay, so thank you again. I hope you guys have got something from our discussion today. So back to you, Mr. Andredas.
Okay, we shall continue with the rest of the conference, but before we go on, I also like to thank the trauma people for the excellent presentation in such a short notice that we gave them. And I hope you all will join us for the rest of the conference. Thank you.
It is like our life. We got short notice to operate, we got short notice to stop.
Yeah, we know your capability, that's why we test you to the thing.
It's okay, no problem.
Mr.
Thank you very much.
Thank you.
Thank you very much.
Everyone.
Okay, thank you.